So scrolling from superior to the inferior sections, the area shown here with the pointer is the torus tubarius, which is a part of nasopharynx, because anteriorly there is nasal cavity and posterior to that we have nasopharynx. And this is torus tubarius. Torus tubarius, this is eustachian tube orifice, and just posterior to the torus tubarius, this depression, this is fossa of Rosenmuller, fossa of Rosenmuller. Important because it is a site of origin of nasopharyngeal carcinomas in older population. And another DD of nasopharyngeal carcinoma is lymphoma, which happens in uh, nasopharynx. And in a younger population, a mass in this region can be juvenile nasopharyngeal angiofibroma, that is JNA. But the difference is that it will not be epicentered in this fossa of Rosenmuller. It will be somewhat anteriorly epicentered. I will show where is the sphenopalatine foramen, where JNA is epicentered. For the time being, let's remember this is the fossa of Rosenmuller, and the soft tissue anterior to that, this is torus tubarius, and this small depression just anterior to torus tubarius, it is actually eustachian tube orifice. Now in the nasopharynx, when we are scrolling down, there is nothing much to say. Just remember that small cystic area can be there in the posterior wall, which is usually the thorn wall cyst, which should not be missed, and it can come as a spotter in the exam also. And regarding the muscles of neck, I will tell later on. Just quickly reviewing the anatomy of oropharynx. So this is the region of oropharynx. Why we are saying that? Because we can correlate it with the sagittal images, and the region which is behind the line passing through the hard palate and soft palate is usually oropharynx. So this is the region of oropharynx, and when we are scrolling down, yeah, this is soft palate actually, and further scrolling it downwards. So this is a small projection of soft palate which is hanging downwards. So it is uvula, and uvula is having, or we should say, soft palate, which is actually uvula is a part of soft palate. So this is soft palate only. It is getting attached to the pharynx with the help of palatopharyngeal muscle. So this is basically the posterior tonsillar pillar, which is constituted by palatopharyngeal muscle, and in this region there will be anterior tonsillar pillar, which is usually palatoglossus muscle, but it is very hard to demonstrate this muscle on CT images. So just remember that in this section at this level there will be palatoglossus muscle, and here the palatopharyngeal muscle is shown, that is anterior and posterior tonsillar pillar, and this is the region of tonsillar fossa. So this is the region of tonsillar fossa. So in children, sometimes the palatine tonsils can be enlarged, or sometimes a tonsillar mass may be there in an adult. So we should look for this area, this area. So this is the tonsillar fossa. And when we are scrolling downward, this is basically the oral part of tongue, and in this region sometimes lingual tonsils can be there, and when we are scrolling downward, then this is basically actually tongue only. And in tongue we must remember that there are four intrinsic muscles which forms the core of tongue. For example, when you see the sagittal images, so the upper part of tongue, this core of tongue, is predominantly found by the intrinsic muscles, which are like longitudinal muscle, vertical transverse muscle, and the longitudinal muscles are again superior and inferior longitudinal, then vertical or transverse muscles. These are the intrinsic muscles of the tongue. And apart from that, there are few other muscles, a fan shaped muscle which originates from the genial tubercle, and it fans and goes like this, and it is better to see on the axial images or on the coronal images. So the muscle which is kind of forming a or inverted V kind of configuration, it is genioglossus, and the easiest muscle to identify, it is an extrinsic muscle. So one of the extrinsic muscle is genioglossus, and in between this fatty area is forming the lingual septum, that is separating the right half of tongue from the left half of tongue. And then other extrinsic muscles of tongue are constituted by styloglossus, which will be found somewhere in the posterior part, and then hyoglossus, which will be somewhere laterally, and genioglossus I have shown, which is easiest to identify, and one is geniohyoid, which forms the floor of mouth also. I will show later on. And another muscle which is very important to remember in the axial section is the muscle which is lying laterally. So we can correlate it with the coronal sections, and it will be a U-shaped muscle, and which is known as mylohyoid. So we can easily see that this muscle is going like this, going like this, going like this, and going like this. So it is a U-shaped muscle. Just look at the pointer, U-shaped muscle, which forms the floor of mouth, and it is mylohyoid. And floor of mouth radiologically is made up of three muscles, not just mylohyoid, which I have shown here. Along with that, we have another muscle which is seen like here, and this is the anterior belly of digastric. Anterior belly of digastric. In between them, there is a region called a submental space where 1A group of lymph nodes can be there. So this is the submental region, 1A group of lymph node, right and left anterior belly of digastric, which are shown in the coronal sections in the inferior most part. So this is the anterior belly of digastric. This is U-shaped muscle, which is called as mylohyoid, and the third muscle which forms the floor of mouth radiologically is geniohyoid. So geniohyoid will be found resting on the top of this mylohyoid in the midline like this, and genioglossus is seen like this with the fatty area forming the lingual septum in between. And apart from that, always remember that all these muscles will be better delineated on MRI, because the soft tissue resolution of MRI is much better than CT. So after reviewing the areas of oropharynx and the oral part of tongue, you must remember that the anterior two-third of tongue is a part of oral cavity, but the posterior one-third of tongue or the base of tongue is a part of oropharynx. So if a mass is there which is epicentered in the posterior one-third, then we should say it is a oropharyngeal carcinoma, because the staging will be different from the oral cancer or the oral part of tongue, which will be in the anterior two-third of the tongue. So now when we are scrolling downward, we are seeing that this is the hyoid bone, and this is the body of hyoid, and then there are superior cornua and inferior cornua. So this is the large cornua, which is the inferior cornua. Superior cornua is this very small dot-like structure. So if you see, like this would be a superior cornua. This is the body, and the large chunk is the inferior cornua of hyoid bone. And we are seeing that in the soft tissue window, we will be seeing that the leaf-like structure is there, which is epiglottis. It is a cartilage of larynx only, and this cartilage, it is forming these two hollow areas anterior to that. These are the vallicular, right vallicular and left vallicular, because a thyroepiglottic membrane or a hyoepiglottic membrane is present in between. So this is the part of larynx only, and this is the hyoid bone. And when we are scrolling downward, furthermore, we are seeing that this region is called the aryepiglottic fold. And again, on the left side, we are seeing aryepiglottic fold. And lateral to that, this air-filled area is known as the piriform sinus. We can correlate the piriform sinus on coronal images also. So, and making it more symmetrical. So this region is the piriform sinus. Okay, so this is piriform sinus on right. This is the piriform sinus on left, and you can correlate it with the uh, sagittal images also. See that this leaf-like structure is epiglottis. We can correlate very easily. Yeah. So this leaf-like structure was epiglottis, and this fatty area in front of this epiglottis, we are seeing this is the pre-epiglottic space. Okay, so anterior to that, the fatty area we are seeing is the pre-epiglottic space. So this is a part of pre-epiglottic space only. In some kind of epiglottic mass or laryngeal mass, we can have the infiltration of this pre-epiglottic space in which the fat will be obliterated and not seen. It will be replaced by the mass. So this area should also be looked for, and it is better seen on the sagittal images. So now let's further go ahead, and we will be seeing and moving downward. So this is the thyroid cartilage. Okay, this is the thyroid cartilage. This is the thyroid cartilage, and the outer aspect of thyroid cartilage has attachment of infrahyoid muscle or the infrahyoid strap muscles to be better called. So these are the strap muscles. Sometimes you can have a laryngeal mass which will be destroying this thyroid cartilage, and it will be having extra laryngeal spread, and the strap muscles will be infiltrated or invaded by the soft tissue. So this strap muscles area should be looked for. This thyroid cartilage area should be looked for any obvious defect or any suspicious sclerosis. And suspicious sclerosis, we can say if this area of fat attenuation between the outer and the inner cortex is replaced and no such medullary fat is seen, then we can say that it is abnormally, it is sclerosed. So in this area we can see that the ossified part of thyroid cartilage is there, and in the center it shows a medullary fat. But if it is abnormally sclerosed, then this medullary fat will be lost, and it is a very subtle sign. And more commonly we will be seeing a large mass in the larynx would be there, and it will be completely destroying, and it will causing the lytic destruction of the thyroid cartilage, and it will be going in the extra laryngeal space, invading the strap muscles also. So these areas should be looked for. And then now we are going downward, and what we are seeing is that in the center part we have the cricoid cartilage, and on the lateral aspect we have this arytenoid cartilage tip. And sometimes this is basically the cricoarytenoid joint. So we must remember that at the level of cricoarytenoid joint we have true vocal cords, which are actually we see thyroarytenoid muscle in this region. So this region of muscle kind of attenuation is thyroarytenoid muscle, and at the level of cricoarytenoid joint we are seeing this. So this is true vocal cord, which is on the inferior sections, and when we move superior to that, so this region is of fat attenuation. So uh, when we see fat attenuation at the superior sections, this is false vocal cord, and this is basically the paraglottic space, and which is containing the fat. But this section is of false vocal cord. But when we move inferiorly and when we see the cricoarytenoid joint and the muscle kind of attenuation, then this is the true vocal cord. And we should always look for the shape of the true vocal cord, because sometimes sail sign can be there, and in the sail sign you will have the medialization of the posterior part of the true vocal cord. So this part will not be here, this part will have moved here, and a sail kind of configuration would be there, and that is a sign of vocal cord palsy, which can be because of invasion or involvement of any particular nerve, which can be the branch of vagus nerve by the other mass. So when we are scrolling it further downward, we are seeing that this is the cricoid cartilage. One more thing I have to mention is that sometimes the mass can be crossing the anterior commissure and going on the contralateral side, or it can be crossing the posterior commissure and going on the contralateral side. That has to be mentioned. And sometimes the mass can go in between the cricoarytenoid joint, and it will cause the widening of the space. So the area which we are seeing is the joint space. Sometimes this joint space can also get widened because of the infiltration by mass. So we have to report that. So suppose if we correlate this on the coronal images, which is the best thing for laryngeal anatomy. So this is the region of true vocal cord. So this is the region of true vocal cord, and let's move ahead. So this is the region of false vocal cord, because paraglottic fat is seen at this level. So the region between true vocal cord lying inferiorly and false vocal cord lying superiorly, this is known as the laryngeal ventricular complex or laryngeal ventricle, and basically the false vocal cord is said to be part of supraglottis. So what constitutes the supraglottis? Basically the epiglottis, vallicula, and then this aryepiglottic fold, the piriform sinuses, and then the false vocal cord also. Everything till this level is a part of supraglottis. And when we see the cancer involving the ventricle, that is inferior part of the false vocal cord till true vocal cord, then it is called as a glottic carcinoma. And when it is below the level of this true vocal cord, then we say that it is subglottic. But subglottic carcinomas are very rare. Usually, we will encounter supraglottic or glottic carcinomas, or sometimes transglottic carcinomas also. And you should remember that supraglottic carcinomas more often lead to lymph node involvement because lymphatics are rich in the pre-epiglottic space and paraglottic space. So the lymph node involvement in the neck will be more common in the supraglottic carcinomas. And apart from that, we can quickly go ahead with the muscles that we can encounter in neck. So from the superior most section, this is the lateral pterygoid plate and this is the medial pterygoid plate. In between them, there is a pterygoid wedge. Important because sometimes a JNA case, that is juvenile nasopharyngeal angiofibroma, when we are reporting, we must remember whether that mass is going into the pterygoid wedge or not, because intraoperatively for the surgeon to remove the JNA from pterygoid wedge is difficult, and post-op residual tumor can be left behind in this space. So the pterygoid wedge should be looked for in a case of JNA, and it is peculiar that both the lateral pterygoid muscle as well as the medial pterygoid muscle, both of them originate from the lateral pterygoid plate only. So in the superior section, you will see the lateral aspect of the lateral pterygoid plate give rise to a muscle which is the lateral pterygoid muscle. Again, it has superior and inferior head, but not important for us. And as we are scrolling down, 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 we are seeing that yes, this muscle is coming from the inner or the medial aspect of the lateral pterygoid plate, and then it is going towards the angle and ramus of mandible. So this is the medial pterygoid muscle, which is in the inferior part, and this muscle is the masseter muscle, and which is inserting on the outer aspect of the mandible, and we can scroll it upward, and we can see that this is the masseter muscle, and this triangular shaped muscle is temporalis muscle actually, and for any muscle or any vessel identification, we can trace it and scroll the images, and when we are scrolling it upward, this triangular muscle is attaching on the squamous part of temporal bone. So this is temporalis muscle actually. This triangular muscle is temporalis muscle. This muscle is masseter muscle, and masseter muscle is looking somewhere different here and then getting inserted over this part, looking somewhere different here because it has a deep and superficial part, just like the medial pterygoid muscle, which is also having superficial and deep part. And the lateral pterygoid muscle has superior and the inferior part. But these things are not important for us. Just identifying the muscle is suffice for us as a radiologist. And this is a very important muscle. This is the sternocleidomastoid because it helps us to delineate the level of lymph node stations also in neck, which will be discussed later on. So this is the sternocleidomastoid muscle. You should always remember, and you can follow it to get its insertion on the sternum also, in the middle part of clavicle also. Yeah. Apart from that, sometimes when we are describing the mass, we have to tell that the mass is epicentered, suppose in the fossa of Rosenmuller, and then it is involving which all species. So the next species is a separate topic, but in a nutshell, I can tell that this lining of the mucosa of the pharynx, we can say that it is a pharyngeal mucosal space. And then apart from this pharyngeal mucosal space, the parapharyngeal space that is lying adjacent to the pharyngeal space contains this fat. So this is the fat which is lying in the parapharyngeal space. So if some mass is there here and the fat is not seen as compared to the left side, then we will be saying that the fat in the right parapharyngeal space is obliterated and it has been infiltrated by the soft tissue attenuation mass. So we can say we can identify this fat and we can say that the parapharyngeal space is normal, the pharyngeal mucosal space is normal. Then we have to trace the carotid vessels and we have to tell about the carotid space, which is a part of, according to some authors, a part of or the posterior part of parapharyngeal space only. Then we have to look for this gland, which is the parotid gland, and in old age it can be showing the fatty attenuation also because it gets replaced by fat. And the other things uh, like This is the